Welcome back to Barton EMS Education. This is the EMT preparation for the Module 2 exam, talking about cardiac emergencies. I'm Nick Larmer, and I'm going to be talking to you today about the different types of cardiac emergencies. Now, I do want to make a caveat. I'm not going to hit on all the signs and symptoms because signs and symptoms tend to change from year to year. So if we're using these videos in the future, I want to make sure that they're consistent and that they're concise. So we're not going to spend too long covering these because I want you to get the information. But for the signs and symptoms for most of these emergencies, I would like you to consult the Merck manual. I'll cover some of them, but I'm not going to cover every single sign and symptom because we would be here forever. So I want you to stay tuned, stay with me, and we're going to get through these cardiac emergencies in hopefully less than 6 minutes. So let's dive right in to understanding cardiac emergencies. So we're going to talk today about angina, acute myocardial infarction, abnormal heart rhythms, and cardiac arrest. These are probably the 4 topmost cardiac emergencies you're going to be presented with in the field of EMS. Now, however, congestive heart failure does fall into this, but I don't tend to use congestive heart failure along with this because I tend to see it as a respiratory emergency, but it is also a cardiac emergency. Now, the heart's anatomy and physiology, I think it's important that we quickly cover over this, that the deoxygenated blood is coming back to the heart, through the veins, into the right atrium, into the right ventricle, gets pumped out to the lungs, and we exchange oxygen and CO2, and it comes back the pulmonary veins, back to the heart, and comes back into the left atrium, goes through the mitral valve, also called the bicuspid valve, into the left ventricle, the workhorse of the heart, squish, and it pushes it out through the aorta, and then it gets to the body. And once it gets to the body, we go through the arteries, to the arterioles, to the capillaries, back through the venules to the veins. Just like if we say bronchi, bronchioles, alveoli, the bronchi are bigger than the bronchioles, and then their bronchioles are bigger than the alveoli, but gas exchange happens at the alveoli in the capillary beds. Same thing's happening inside our body when we get down to our little phalanges in our fingertips. We have oxygen exchange happening at those fingertips because of the arteries carrying to the arterioles, which are smaller than arteries, and the arterioles carry to the capillaries, and we have oxygen exchange going from an area of high concentration to an area of low concentration with diffusion, where it's going across and we're exchanging oxygen, we're taking CO2 back and we're sending it back to the heart. The deoxygenated side of the heart is always going to be the right side. The oxygenated side of the heart is always going to be the left side. The aorta is going to, as it's getting squished out, is also going to deliver blood to the heart through the coronary arteries. Those arteries, if they become blocked, we're going to have ischemia, lack of blood supply to the heart, which eventually is going to cause injury where they got chest pain, showing that Levine sign, and that chest pain is then eventually going to cause someone to develop what we call infarction. Infarction is death. If you said someone had a brain infarction, a kidney infarction, they have a liver infarction. It's death of tissue. And so the heart muscle, when it dies, a whole bunch of cells make up tissues, a whole bunch of tissues make up organs, and organs make up systems. And so when the heart muscle dies, it has an infarction. So the myocardial, that's the muscle of the heart, acute is right here, right now. So acute myocardial infarction is going to cause the heart muscle to die. So the heart anatomy is very important because not only do we have this anatomy that is the mechanical system, but we also have an electrical system. And that electrical system, we start at the SA node, we move to the AV node, we move to the bundle of His and the right and left bundle branch, and then we go to the Purkinje fibers. If these people in this electrical system are not doing their job, different parts and pieces are going to take over. And so when you get into more advanced settings and we understand that the SA node is the pacemaker of the heart, the AV node is the junction in between the atria and the ventricles, if these are not doing their job, the other ones are going to take over. If the SA node's not firing, the AV node's going to fire. If the AV node doesn't fire, the ventricles are going to fire, and so on and so forth. And that's how we get different rhythms. If we have a VTach rhythm, ventricular tachycardia, it means it's originating from the ventricles, and it's a fast heart rate above 100 beats per minute. If we have a sinus bradycardic rhythm, that means it's originating from the sinoatrial node, and that sinoatrial node is the pacemaker of the heart. So it means it's a slow heart rate, but there's everything that needs to be there. So when we see this wave with a PQRST, the EKG wave, and we do a 4 lead or a 12 lead, we have to understand that all of these things are important. Now, we're getting very close to that 6-minute mark, so we might go over just a little bit, but let's keep on trucking on. So, heart anatomy and physiology, we have to understand that cardiac output equals heart rate times stroke volume. The stroke volume of the heart, when the heart goes squish, and the amount of pressure that it kicks out with the preload and afterload, that factors into stroke volume, as well as the heart size, their fitness level, their gender, and the ability for contraction. However, their hormones, their fitness level, and age affect the heart rate. So heart rate times stroke volume equals cardiac output. So 2 times 2 equals 4. And 4 is going to be our cardiac output, and that's maintaining homeostasis. So if we decrease heart rate to 1, what is it going to take to still equal 4 in the cardiac output? We're going to have to increase to 4 in stroke volume to equal 4 in cardiac output. Here's another breakdown here of the factors affecting stroke volume. Venous return, the filling time, how the electrical system was working, hormones, vasodilation, vasoconstriction. It affects preload, afterload, and contractility. And all of these affect our stroke volume. And our stroke volume is your end diastolic value and your end systolic value, or your volume, and those affect your ability for stroke volume. Now, the things that affect your heart rate is the ability for the atria, as well as hormones and the autonomic innervation, and that's your heart rate. So are we having a sympathetic or parasympathetic response? And so those things together, heart rate times stroke volume equals cardiac output. And this is what we need to understand with, if there's an issue with blood supply, if there's an issue with the heart rate, and we have an arrhythmia, we're going to decrease cardiac output, which thereby is going to cause the body to start going into a form of compensated shock, decompensated and irreversible, which we call this all-encompassing term cardiogenic shock. So the first issue I want to talk about that falls under acute coronary syndrome. Syndromes is a whole bunch of signs and symptoms that fall into this list. And acute coronary syndromes, coronary, talking about the heart, talking really about the coronary vessels. And then acute is right here, right now. We've talked about acute several times. So we have 2 types of angina. We have stable and unstable angina. And then we also have our injuries, our ST elevated myocardial infarction, that when we have those happening inside the body, we see ST elevation, or we see non-ST elevation. That's what we call an in-STEMI. These two, in-STEMI and STEMI, are when we start having injury that's leading to infarction. We have lack of blood supply, ischemia, which then leads to injury, which then leads to infarction, which is death of tissue. All right, angina is where we have a increased demand workload on the heart because we have a blockage in there. And that blockage is plaque or narrowing of the arteries, and it's normally relieved with nitro. So, and it's caused by exercise-induced problems. So if someone is working out, they start having chest pain, we give them nitro, it takes care of it, it's more than likely that they have angina. Now, if we give them nitro and it doesn't take care of the issue, we're more than likely looking at the injury infarction, but we're hoping to open up those coronary vessels with the nitro as to allow the blood flow to return to the heart so we can reperfuse the heart. The other thing that we have to understand is that when we're talking about the heart and we're perfusing the heart with nitro, nitro is going to only really vessel dilate the coronary arteries, as well as, when we have a STEMI, we have these blockages. So we're hoping to dilate that, but we also want to make sure that we prevent any further clots, and that's why we give aspirin at 481 milligram tablets, 324 milligrams total. Now, our acute coronary syndromes, there's several different ones that we can do, but these are your ones that are going to present with chest pain, shortness of breath, diaphoresis, they're sweaty, and they have radiating pain. It doesn't have to happen all the time just like that, but they can also have nausea, they can have abdominal pain. Everybody's going to present different. Symptoms are what they tell you, signs are what you can see. So remember that and understand that, if they have chest pain, we need to make sure that they're not having a heart attack, and we kind of go down that rabbit trail and make sure that we are pretty darn sure that they're not having a heart attack at this current moment in time, and it's more shortness of breath, it's more respiratory in nature, or if it's abdominal pain, or maybe it's something completely else. At having that good differential diagnosis. Acute myocardial infarction, we've talked about that death of the tissue. People are going to describe it as that sudden onset of chest pain. It's radiating to their back, neck, jaw. They're having a crushing tightness. Feels like someone's sitting on their chest. They might be nauseous. They might be vomiting. They may have extreme weakness. It's going to cause damage to the muscle. And when that damage is caused to the muscle and we can't perfuse the whole body, there's going to be issues. So understanding that the mechanical system and the electrical system work together, it's going to help us understand about acute myocardial infarction. Now, if we can't do anything before we get to this acute myocardial infarction, maybe there was an arrhythmia that caused this. Maybe we had tachycardia or bradycardia. And maybe there was an arrhythmia, and so they had a pacemaker placed. And so we have a raised bump up on their skin showing a pacemaker. But understand that arrhythmias eventually will cause problems down the road. It's not something you can live with forever. Arrhythmias is an abnormal heart rhythm, and the heartbeat originating from either the SA node, the AV node, or the ventricles, and those are going to cause issues. So we have to understand this, and if we get V-tach and there's no pulse, we're going to start something what we call cardiac arrest. And the two big things that I want everybody to understand with cardiac arrest is good quality chest compressions, and early defibrillation is what saves lives. It's not all the drugs, it's not the IV, it's not the IO, it's not the supraglottic airway that's going to get put in. Good hard chest compressions and rapid defibrillation is what saves lives. Now, cardiac arrest, that early activation is done by the lay public, and that's when we show up and we take over and we run the code. But there's a good chance we may not get these people back. So we need to understand that, but we need to do the best we can with the circumstances we're presented with. That's a quick rundown on your cardiac emergencies, running through what you've covered in your courses from your instructors. And I just want you guys to understand that cardiac emergencies are going to present with varying different systems that are going to have symptoms and signs, but we need to refer to the Merck manual on what are those signs and symptoms, and we need to understand that there are going to be some signs and symptoms that are not going to be in the list because everybody's different. Everybody's different. People present differently, and we have to remain critically aware of the surroundings and be ready to handle the situation on how it presents itself to us. Thanks and have a great week. Continue watching on to the rest of the videos and learn more about the different learn more about the different emergencies that you're going to be tested on your upcoming exam. Good luck and Godspeed.